Okay, thank you. So we move on the next presentation by Dr. By Dr. Hadjiadoni. Hadjiadonis. So the topic is CMR in neuromuscular disorders. Dr. Hadjiadonis. He is expert on cardiovascular imaging modalities, so we are going to enjoy.
I think he's a lecturer. He's a lecturer in Munster, something like Münster. I don't know. I cannot, let's say, pronounce it very easily. It's from Germany. It's Germany, huh? But here it's Coitas. It's here.
Thank you very much. Thank you for your kind words. It's really a pleasure to be here. You pronounced it really well, I think. It's Münster. It's with the umlaut, as we say it. The University Hospital of the Münster in the North Rhine-Westphalia. But I'm here from 2020 back in Greece and performing CMR. Hopefully in a high level. It's always a pleasure to be here in where it all started with Professor Mavrogianni, and I'm really pleased to once again share with you as I can the knowledge in neuromuscular disorders and how CMR can help. We should know that NMDs, neuromuscular disorders, is a rare group of disorders causing impairment of the muscles due to injury or dysfunction of the muscles or the peripheral nerves and neuromuscular junctions. So there are collectively impact an estimated of 1 to 3 per 1,000 people worldwide. Due to the low prevalence of the NMDs and the non-specific complaints of the patients, that is fatigue and breathing difficulties, diagnosis is most of the time challenging. Signature symptom is progressive worsening of the muscle and weakness that affects sleight of hand and the ability to walk. There are different NMDs and classified to muscular dystrophies, that is malfunction of the transmembrane protein complexes with associated sacroiliac membrane fragility and subsequent replacement by fibrofatty tissue. Motor neuron diseases, that is the dysfunction of the nerve cells that control the skeletal muscles. Ion channel diseases, altered function in cell ion channels themselves or membrane proteins. Mitochondrial diseases, malfunction of the mitochondria that fail to produce energy. Myopathies, malfunctions of the muscle fibers due to chronic inflammation, metabolic or endocrine disorders, as we will see. And neuromuscular junction diseases, that is the destruction, malfunction, or absence of proteins involved in the transmission of signals between nerves and muscles. And peripheral nerve diseases, that is abnormalities in the peripheral nerve structure that lead to impaired sensation of movement. All these diseases are characterized not only by skeletal muscle impairment, but cardiac muscle is also commonly affected in the NMDs, with the severity and type of cardiac involvement varying significantly between these classes. So we may see a dilated cardiomyopathy, hypertrophic one, restrictive, and we may only see conduction defects or arrhythmias. So the NMDs and the heart, it can do a dilated hypokinetic as Edmund Dreyfus muscle disease or limb girdle disease. It can do a hypertrophic, typical for mitochondrial diseases. So if we have a diagnosis of hypertrophic cardiomyopathy and the patient comes to CMR and has a not so typical pattern in the late enhancement, one should assess further. That is the same for glycogen storage diseases and Friedreich's ataxia. Restrictive, typical in myofibrillar myomyopathies, and where no cardiomyopathy is seen in imaging, but we see arrhythmias such as in myotonic dystrophies. So nicely depicted from Professor Marinos Dalakas, there are many proteins all implicated in the NMDs associated with cardiac involvement. And if one pathway doesn't work, then it begins with problems in our patient in the skeletal, but also the cardiac muscle. As many of the patients of these patients are limited through their immobility, the typical symptoms of heart disease, one can assess that the reduced ability to exercise or the shortness of breath, lack appetite and nausea are hard to identify. That's why cardiovascular imaging plays a key role in identifying these patients with cardiac involvement that could benefit from early treatment or have also a better overall prognosis. So, in the 2023 guidelines for the management of cardiomyopathies, one, in the clinical approach of infantile and childhood cardiomyopathy, should assess, of course, the inheritance pattern. If someone in the family has an NMD, one should be more careful, of course. ECG is the first line in our diagnosis workup, and echocardiography could show a concentric left ventricular hypertrophy, as in Friedreich's ataxia, or really extreme, as in Danon disease, global hypokinesia, and typically in desmosomal cardiomyopathies, or akinesia in dystrophin diseases, pulmonary diseases in neuropathies, and many others. Naturally, these patients don't have only the cardiac involvement, they have a systemic phenotype, and we do it as cardiologists vice versa in order to be true. We get the image, we see the cardiac problem, and we should assess the phenotype in order to match the puzzle and may help the patient and the colleagues in further investigation. So if there is any dysmorphia, skeletal abnormalities, if there are skin abnormalities, one should look. Metabolic acidosis, typical in mitochondrial diseases or encephalopathy, hypoglycemia, ataxia, muscle weakness, deafness, learning difficulties, intellectual disability, one should be careful of this systemic phenotype. So, the diagnosis of NMD and how should we evaluate this patient? When we have the diagnosis of NMD and we look up for cardiac involvement, we have the imaging with echocardiography that should be performed annually, and of course CMR, not annually if it's not a disease that typically affects the heart, but if echocardiography is not diagnostic, and in order to evaluate a known fibrosis at an early stage, CMR is in the center. ECG monitoring, of course, is important. Annual follow-up, as some of the patients, as we told before, like in myotonic dystrophies, might not have an clinical cardiomyopathy. One should assess the ECG, of course, at the beginning, and depending on the symptom frequency, Holter or even loop recorders. So, what do we assess in the ECG? Absence of sinus rhythms in these patients, atrial fibrillation or junctional rhythm may be suspicious of a cardiac involvement, atrioventricular or intraventricular blocks, low P wave amplitude, P-air interval prolongation, and QRS widening. In the 24 ECG, we search of atrial tachycardia, atrial flutter, fibrillation, but of course also ventricular tachycardias. Transthoracic echocardiography, of course, as we said, annually, we search for left ventricular hypertrophy, we search for dilatation, we search for left atrial dilatation, which may be prominent, and we search for regional wall motion abnormalities. So, of course, the left ventricular ejection fraction itself, it's not that sensitive for the diagnosis. That's why, once again, this group will benefit from a strain analysis, and the left ventricular ejection fraction could be replaced or added its value with the left ventricular global longitudinal strain, which is more sensitive to find early cardiac involvement and if we see something there, to assess the patient and go for the CMR. Laboratory tests are important. See creatinine kinase activity, lactate and pyruvate analysis, but also cardiac troponin. Genetic testing plays also a significant role. It's not that easy. Only 20% of the NMDs patients do get finally a diagnosis with gene testing, but one should be done and plays a key role because it permits institution of specific treatment if available. Maybe we can avoid unnecessary testing and exposure to potentially harmful interventions. We can assist prognostication, which is significant for the patient to know. We can assist genetic counseling for the affected patient and other relatives that are potentially at risk, and allows monitoring for other organ involvement. And of course, if it's possible and if we have a gene, we can collect more data in clinical trials and help the patients in the future. So we have a suspected inherited myomyopathy. We should evaluate the phenotype, and depending the phenotype, do the gene testing. And if we find a diagnosis, that's fine, that's good. But if we have a negative test result, then we may reevaluate the phenotype. We may consider a muscle biopsy, and of course, serological testing. So, guidelines, the European guidelines for cardiomyopathies put CMR with a 1B indication as a recommendation for patients with cardiomyopathy at initial evaluation. Because CMR has a good added value, we have collective data from over 2 decades now in study cohorts comprising of different NMDs. We have high reproducibility of this data and low inter-observer variability. We can assess global and regional function and presence of fibrosis or fat infiltration, detect of early myocardial changes, and guide appropriate treatment, altering the prognosis of these patients. And this we can do with accurate measurement of the cardiac function, CNA imaging, balanced steady state, free precision. It's of course important for the volumetry. Myocardial edema assessment and inflammation, the T2 weighted sequences, we can evaluate at first visually and semi-quantitative, but also naturally with a T2 mapping, a quantitative assessment that if we do a follow-up, the mapping can help us identify small changes and help early detection. Myocardial fibrosis and injury, late enhancement, really important. And deformation, feature tracker, myocardial strain analysis can be done post-processing. So we do the normal CNA imaging, and if we see something that doesn't sum up correctly, we can do the strain analysis on top. And there are studies that this strain analysis is and can be better than what the ultrasound, the echocardiography can perform. Diffuse subclinical myocardial fibrosis, T1 mapping, a quantitative assessment, of course, and estimation of the extracellular volume with T1 mapping pre and post contrast. So CMR in the NMDs can have a typical late enhancement. In the Duchenne patients, Becker patients, also carriers, we see a subepicardial to mid-myocardial late enhancement in the infero and inferolateral wall. In the myotonic type 1, we see mid-myocardial of the septum and basal inferolateral wall. Type 2, mid-myocardial of the inferolateral wall. Limb girdle and Dreyfus muscular disease, Edmund Dreyfus muscular disease, dystrophy, have a pronounced mid-myocardial late enhancement in the basal to mid-septal wall, and hypertrophic cardiomyopathy and T10 mutations can have mid-myocardial late enhancement in the whole myocardium. So in this patient with Duchenne cardiomyopathy and a dilated left ventricle, we measured at first in the senior imaging, and we can assess the function. And 2A and 2B, we can see the late enhancement, how diffuse it is in the supraepicardium, the two almost transmural late enhancement in the whole lateral wall, extending also in the mid-myocardium of the septum. And of course, the strain analysis, as we told before, can see subtle changes, as you see here in the mid-lateral wall, and that is the extracellular volume extraction that we get, and how in the areas of the late enhancement is pathologically elevated. From the same paper, this is a Baker patient, also with typical late enhancement in the basal inferolateral wall, supraepicardium, and one can see it also in T1 mapping and assess the whole myocardium and have a measurement in order to see if the patient gets a therapy and have a follow-up to have a quantitative assessment if this treatment really helps or not. And from my data, personal data of patients, that is a patient with a Becker muscular dystrophy, a typical thin supraepicardial late enhancement in the basal inferolateral wall. And as you see it in the short axis, it extends to the lateral and almost anterolateral wall. It's not easy to make the diagnosis, so this is nice to see, and one can really extract the image easily and see the supraepicardial late, but it can be related with a previous myocarditis, for example. So that is where other stuff, as we said before, the phenotype is important to assess what the patient has, if it has any other symptoms, any other neurological symptoms. One should think about it. That is an intermediate form between Duchenne and Becker muscular dystrophy. You see the extent of the late enhancement is really, really big. It's transmural from the inferior wall to almost anterior wall. And that is a patient with a myotonic dystrophy type 2. It has typical supraepicardial late enhancement of the whole septum from basal to mid, and extends also to the septum mid wall. And this patient, it was at first diagnosed as hypertrophic cardiomyopathy, as many of them do. And seeing this pattern, that it was a little bit of too extensive and atypical for hypertrophic cardiomyopathy, we assessed further, and it was at last a mitochondrial encephalopathic lactic acidosis and stroke-like episodes of MLS disease. So what is the diagnostic and prognostic value of CMR in neuromuscular cardiomyopathies? That is literature with a Greek contribution from Professor Adonopoulos and Vlachopoulos. This cohort of 111 patients with different neuromuscular diseases, as you can see here on the right, were assessed. And we see patients with mitochondrial cytopathy presenting with a HCM phenotype, after 5 years, extensive mid-wall, atypical for HCM late enhancement. He had a Friedreich's ataxia, HCM at the end. But also Friedreich's ataxia can present with hypokinetic, non-dilated cardiomyopathy phenotype with extensive late enhancement, almost circumferential here, and with impairment of the left ventricle function. Becker muscular disease, as we saw before, a typical late enhancement supraepicardial on the lateral wall, or with a severely dilated left ventricle with severely reduced ejection fraction, also patient with a Becker muscular dystrophy, patient with a Duchenne dystrophy with typical inferolateral late enhancement in the basal wall, basal inferolateral wall, as we see it here, also almost transmural. So from this cohort, from these patients, they did a Kaplan-Meier examination and assessment of an end type of death, hospitalization for heart failure, and implantation of pacemaker or defibrillator. Of course, it was different among the different NMDs, but what was really important was not only the ejection fraction that was a predictor for a worst outcome, but also the presence of late enhancement. So you see, if there is a presence of late enhancement, then the prognosis of the patient is worse. And of course, if it is concomitant with an impairment of the left ventricular ejection fraction, is even the prognosis is worse. So the CMR can have early findings to detect subclinical cardiac lesions and risk stratify patients with Duchenne. That is from Professor Mavrigiani. Late enhancement in the basal inferolateral wall, concomitant edema in the same area as also seen in mapping. And this can help us assess the patient. The old methods and the new that are not new, I think, anymore, and are in everyday praxis, the mapping T1 and T2, to help us also have a quantification and assess patients that have a CMR follow-up. Thank you very much for your attention.
This is a very comprehensive talk. You have presented many data, several data on this group of patients with NMDs. I think I would like to ask you a question, and we have a question from the audience. So I would like to ask you if you use diastolic data in this group of patients using CMR, because there is a few papers on the prognostic role of diastolic data derived by CMR in, I think, Duchenne muscular disease. And and another question, do you think that the ring-like LD is often in this group of patients, or is not?
Yeah, that's really, really good questions. To begin with, a ring-like LD, of course, the first differential that comes to mind when we see that is arrhythmogenic cardiomyopathy. So mutations from lamine or dystrophin and all the arrhythmogen genes that can do that. But if we assess the phenotype of the patients and if there are any other red flags, one should think also that the patient may also have an NMD that wasn't diagnosed until we did the CMR, and that's not that uncommon. But you correctly say the first thing when we see a ring-like, it's an arrhythmogenic cardiomyopathy of the left ventricle. If we also see abnormalities in the free wall of the right ventricle, then the suspicion is higher. But one should not wipe out the NMDs at all. The diastolic data, as you say, we derive them from a strain analysis and from measuring also from the atrial also. We don't really use it in our clinical or scientific search, so I can't say I have a personal experience from that. I think it's a little bit more difficult to assess diastolic function with CMR as one thinks. I think the ultrasound, the echocardiography, with all the flow measurements that can do have more parameters there to assess.
Which is the role of biochemical markers, such as troponin or BMP in this group of patients, and which is the role of also of genetic tests?
Biological, of course, a significant role in the prognosis of the patients and the follow-up. As every cardiomyopathy, it's of course the same. Troponin can show us cardiac involvement and can show us worse prognosis. One should be careful because and should use the troponin I more because it's more specific for the heart muscles. Of course, this group of patients do have elevated CPK and troponin T because of their neurological and skeletal muscle problems. So one should be careful when assessing this. And naturally, NT-proBNP, significant role. Of course, one should have in mind if there is an elevation, if it's coming due to heart failure or also an atrial flutter or atrial tachycardia. That is also a common presentation from them for these patients.
We have a question from the audience from Dr. Vorvuri. Myasthenia gravis, do we have data and CMR images?
So for myasthenia gravis, it's a viral disease that does it. CMR data, I do not have it. I do not. I'm not aware of cardiac involvement in myasthenia gravis in order to be.
We published about myasthenia gravis in the past. I mean,
excellent experience.
It's mainly an autoimmune disease because we have blepharoptosis, and I mean, it's mainly a disease from eye doctors, and they refer sometimes. And we examined many patients. We identified only 2 of them with cardiac involvement, similar to that found, but more mild compared to Duchenne or to Baker. But the similar distribution of LGE, but more mild, only small evidence of LGE. But some of them we found an LV dysfunction. I don't know if it was the only responsible the myasthenia gravis. However, we found some. At that time, when we examined all these patients, we didn't have mapping. It didn't exist. So I don't know if I re-examine them with mapping, maybe I find more. But in any case, after examining almost 50 patients, I found only 2 or 3, as I remember. But it was only with LGE and STIR. So maybe they don't have LG and they have only edema, or maybe they have only native T1 and TCV abnormalities. I don't really know because it was not, it did not exist all these indices that time.
I wasn't aware of that.
So,
okay.
yeah.
Thank you.
Yeah, I would like to ask if possible a question to Gregory. I'm just wondering, there are some publications about myotonic dystrophy and the discrimination that you can have with cardiac MRI between type 1 and type 2. So they are talking about infiltration of adipose tissue in type 2, which does not exist in type 1. And there is a more edgy late gadolinium enhancement in type 1 than in type 2. I'm just wondering, I mean, for you are, let's say, CMR specialist. Do you focus on adipose tissue every time, let's say, you have, let's say, CMR, special CMR, let's say, in the patient, or you just, let's say, go through all the other indexes, all the other, let's say, characteristics of the myocardium? Do you stick on adipose tissue, and do you think that is useful in these cases of neuromuscular diseases to try to find outside the heart, or let's say, in these special tissues, to identify the problem for the patient?
So excellent, really. As we said, fat infiltration is also in the heart, in the area where the heart has its injury, to say. So fat infiltration plays a significant role in arrhythmogenesis and plays a significant role in prognosis of a scar, non-ischemic and ischemic. So it's really important not only in NMDs, but also in the differential of subepicardial late enhancement, as we said before, to find inserts in different sequences. Is that T2 steer with fat saturation? Is this the mapping that helps us index and measure there the different times to see if there's a fat infiltration? I really find it useful, the normal cine imaging. It really does a nice artifact there when there is a fat infiltration and one can see it. So really, really important, because these patients can die from an arrhythmia. And it's nice to say there is late and there is basal and the next step is 5 or 7% or 9%. But the fat infiltration is a red flag for arrhythmogenesis and really significant, not only for NMDs and non-ischemic cardiomyopathies, but of course also for the typical ischemic cardiomyopathy.
No, I have a question. I have a question for you, Gregory. Do you ever scan patients post genetic treatment? Because now genetic treatment is very much in fashion, and they try to apply it in these patients.
Nicely questioned. I don't have a patient in my personal data after specific genetic treatment, only the typical heart failure treatment. And there we see an improvement in the T1 mapping, a slight one, I think, but there is.
Additionally, you have to emphasize that these patients with abnormal dystrophin, because some of them have some trace of dystrophin or even total lack, they are very prone to viral diseases, and they develop myocarditis very easily. Just keep it in mind, because they are very sensitive, and when they develop myocarditis, usually they have very bad prognosis, and we have a collection of patients post-COVID, and those with Duchenne muscular dystrophy really had an ominous prognosis.
Of course, because also the lung muscles don't really
function
function together, and
this becomes even worse after such a viral infection.
Okay.
Just last comment, and we can go through, let's say, the next presentation. I'm just wondering, Gregory, you are a cardiologist, no? You're not a radiologist. So
cardiologist.
How easy it was, let's say, in Germany, or because in Greece it's a little bit, difficult to collaborate with neurologists, rheumatologists. I think Sophia, I would like to stimulate Sophie more on this, but okay, just give me an answer. And to congratulate Sophie, because it gives the opportunity to young people, let's say, to appear and show up, let's say, and and so their expertise in the field. And congratulations for this, Sophie. But I would like to ask you, do the neurologists or the rheumatologists or let's say other specialties are keen on collaborating with the cardiologists and the specialists with CMR, let's say in cases with I don't know, neuromuscular diseases or other cases, and are they aware about?
It's a big business to do that. I mean, you have to be in the shoes of the other specialty, whatever you like to develop. So if you like to develop in neurology, you have to come close to neurologists and see what are their problems, how do they think, we are very happy with neurologists. That's because they have very good contact with MRI generally. They know a lot about MRI. You don't have to explain what is T1, T2 mapping. I explain more in cardiologists than in neurologists, believe me. And of course, we explain about function, but function is easy to be explained. All other things, parametric images, are very familiar to this because brain MRI is very over-demanding, and most of neurologists are very familiar with MRI and with CT and artifacts and everything. So it's easy. But we have, as cardiologists, be familiar with their diseases, understand what is neuromuscular disease, what is stroke, what are the tumors, what are the lesions they provoke, what are autoimmune neurological diseases, and how you can help them by performing a validation of the heart. With neurology, I think neurology is easy. On the other side, they are much more open than cardiologists. Cardiologists are very autistic specialty, let me say. They believe they know everything, they possess everything, and they want to control everything. This is not the best way to work in research. With rheumatologists, it's a little bit more difficult just because they are internists, and then you have to come back to your to the time where you were a student and study again. I was lucky because I started working with rheumatic patients when I was a student. So cardiorheumatology for me started when I was in the 4th year of medical studies. I was very lucky having as a main teacher of my clinics a very famous rheumatologist who just came from Paris, Dr. Blamis, and I learned clinical medicine from a rheumatologist. So I'm very, very familiar because before I finished the medical school, I examined already 200 scleroderma, a lot of lupus, a lot of rheumatoid arthritis. This is the clinic of Valti in Thessaloniki, a very, very important, very famous clinic. I didn't have Valti personally, but I have the people who came after him. But the spirit of Valti, that you all have to learn everything and we have to spend time to each subspecialty of internal medicine in order to see what we plan finally to do, was very, very important. And then the clinical training was really excellent. I never had in my life such an excellent clinical training as in Clinic de Valti. So I was very lucky. And of course, I studied a lot after that because current rheumatology has nothing to do with the rheumatology I learned when I was a student. New medications, new things, new techniques. However, I was exposed in a great amount of rheumatic patients. And now I have in my mind all the clinical images I collected during the years I was student and the first years when I did internal medicine. And I had all these images. And when I learned about CMR, I thought that this is the right modality to explore the patients I love and find solutions for the images I have in my brain from the clinical evaluation of these patients. So this is the way that happened with cardiorheumatology and me. It's a long story behind. Nothing happened accidentally.
Love story, I would say.
Yeah, it is a love story. But I learn a lot from rheumatologists, and they are very peaceful, they are very kind. They don't stress you as the professors of cardiology. There is no stress. It's more quiet, the whole thing. So they are ideal people to teach. They spend time for teaching. They are patient with you, patient with your mistakes. They have understanding in many aspects. So it's nice to work with them. And they explain you in parallel. So you learn more. I mean, I enjoy working with rheumatology because I'm learning new things every day, discussing with these people. On the other side, they are very open. They are exposed to many other specialties interaction, and they are very open to new things. So they knew, of course, what is T2 and T1 because they use it for spine, and they created guidelines based on CMR, on MRI of the spine. And one of the person who really worked on this is a Greek chap who is in Germany, Paraliakos. Now he's current president of European Society of Rheumatology. So they are very open to new things. They like collaboration. They are patient. They have understanding. They check things. They are more thoughtful than cardiologists. So this is very good when you plan to do research. So we are a great team. We are friends, and we help each other. For every patient, we discuss long hours until to find a solution. We re-examine the patient, and this is the reason we did all this work. I mean, understanding and best intentions creates the real civilization, I believe. Cardiologists must be more open and less over-possessive and less egoist and less selfish and less arrogant and less aggressive if they want to be real scientists.
No, I think it's
so it's easier to collaborate with other specialties than ourselves.
Maybe you have
so
to
the answer is there.
The conclusion, I think, of your, let's say, presentation is this: be less arrogant.
Be less arrogant.
Okay.
Yeah, and don't believe that you know everything, because nobody knows everything. Only stupid people know everything.
Yeah. But I mean, to be honest, I mean, to conclude, I mean, because I provoked this kind of, discussion, I think that both for rheumatologists, neurologists, and of course for the cardiologists, in the fellowship curriculum, I think it should be implemented the cardiac MRI. Because if, let's say, they see how important information you can get.
But it is part of the training in all European countries, even in Greece, but we don't have magnets to send them because radiologists do not allow to young cardiologists under training to have a training in the magnet. We have so many machines and we don't train cardiologists.
It's not good.
No, it's a problem. I mean, somebody must discuss with the Minister of Health and the Minister of Education. It's political issue, not lack of expertise or lack of machines. We have everything. We don't have brain to use everything. That's the problem. We don't have common sense. And believe that we can keep the situation the way it was 30 years ago. What passed, passed. I mean, we have to look at the future. And we have to work for the future.
Okay.
So, Professor Ageli.
So, thanks, Sophie, for your excellent discussion. So we thanks Dr. Chatzantonis, and we can proceed to the next speaker.